afternoon, everybody. It's my great pleasure to welcome you to the second in our series of lectures from Professor Adam Bagg. Today's talk is going to be on myelodysplastic syndromes, morphology, metaphases, and mutations, and chipping away at the edges. I'm going to start with some housekeeping notes. If I can change the slide, there we go. So recordings can be found on the website. As usual, any questions or comments, please add to the chat box, and I will keep an eye on that and ensure that they are included. Also, if you have any requests for anybody to be added to this mailing list, please contact Melanie. And CPD points will be automatically submitted to the HPCSA for each South African attendee, and you will get you need to attend for 1 hour to qualify for the CPD point, and please give your honest feedback about the session. Upcoming conferences, we have the SASMO and SAS-CETS congresses coming up actually in about a month's time, and you are all encouraged to participate or attend. And then we also have the 14th International Donor Registry Conference coming up at the end of June. And there is a special discounted conference registration rate for delegates. And the abstract submission is now open. I think that it is still open, although the deadline there says 7th of March. Upcoming conferences, again, we've got the 16th annual Heme Onc Symposium in September, which I'm really excited about, and please also feel encouraged to submit your abstracts for that meeting and put that into your calendar for the year. And once again, thanks to our management team, Professor Stelverberg, Gertien Kritzklinger, and Melanie Davids for their excellent management and ongoing work on this project and platform. So I'd like to just introduce again Professor Adam Bagg. We're in for a great treat. Professor Bagg, if you missed the introduction I gave last time, he went to medical school and trained in hematopathology at Wits. And he is now a professor of pathology and laboratory medicine at the University of Pennsylvania in the US. And he has been on sabbatical with us at UCT since the beginning of February. We are very fortunate and delighted to have him with us. He has been for the past 15 years voted by his peers as one of Philadelphia's top doctors, the only hematopathologist in the region. And in 2012 and since, he was noted by the US News and World Report to be in the top 1% of doctors in the US, which is quite an amazing achievement. He has lectured extensively nationally in the US, including at ASH, the American Pathologist Society meetings, and at prestigious institutions like Harvard, Yale, Stanford, Mayo Clinic, and also internationally for international, the European Academy for Hematopathology, International Society of Laboratory Hematology in over 20 countries. He has over 240 publications, many on the molecular pathology of hematological malignancies. Prof. Bagg, we look forward to your talk, and I'm going to stop screen sharing now and hand over to you.
Thanks very much, Jessica. I believe last time I sort of had some comments to make. I was on mute, so I want to sort of reiterate what I said then into the ether and apparently into a vacuum, how appreciative I was of your kindness and hospitality in hosting me at UCT. I've been having a fantastic time. You and the rest of the consultants in your team, and Vernon Lowe's team as well, of course, as well as all the registrars, have been fantastic, and I really had a wonderful time. And just thanks so much for having me. Let me see if I can share my screen. Oh, one other thing I wanted to mention, I'm not sure how many people know about the US News and World Report and that ranking. Basically, if you pay your subscription fees, you get ranked in the top 1%. So that's how that happened for me. So in terms of full disclosure, thought you should be aware of that. Whiteboard. Now I'm not seeing my screen. Hang on 1 second. Having some technical issues here. Give me 1 sec.
You should have at the bottom of your screen
Yeah,
a
no,
little green block.
yeah, no, I'm beyond that. My PowerPoint disappeared from my selection, but I
Okay.
believe I have it now.
Okay,
Can you
great.
see it? You can see it, but it's not in the correct mode and should be in the correct mode. All good. You can see it.
Perfect.
And you can hear me.
We can hear you perfectly. Thank you.
And you can hear the lawnmowers buzzing in the background as I sit here in suburbia.
We can't hear, we can't see you, we can't hear any background interference.
Okay.
So all is good. Thank you.
All right, I apologize. Then you'll just have to deal with me exclusively. All right, so thanks again. The topic is, as advertised, myelodysplastic syndromes. I'm going to be covering a number of different facets of this fascinating group of what now I think are generally accepted, at least by WHO, not yet fully accepted by the international consensus classification as bona fide neoplasms, and focusing on the morphology, metaphases, and mutations. And also talk a little bit about what we've learned about CHIP in the last few years and how that may affect or impact the things we do in working up patients with potential MDS. So I'm sure you're all familiar, but just by way of broad introduction, the myelodysplastic syndromes or myelodysplastic neoplasms are a genetically complex group of neoplasms that are clinically quite heterogeneous and really represent and reflect a spectrum of myeloid neoplasms. They are neoplasms, they are clonal. I think we accept that now today. And a hallmark of this disease, indeed a sine qua non for this disease, the diagnosis cannot be made in the absence of one or more peripheral cytopenias. There are other facets to making the diagnosis that can be dispensed with to some degree, but the presence of cytopenias cannot be dispensed with. The peripheral cytopenia sort of mechanistically, although the mechanisms of MDS are quite complicated, although they are being unraveled recently, are due to ineffective hematopoiesis, something awry in the qualitative nature rather than the quantitative nature of the bone marrow's activity results in the peripheral cytopenias. And indeed, it's the cytopenias, be it neutropenia or thrombocytopenia in particular, and obviously anemia as well, that are the major causes of morbidity and mortality in patients with myelodysplastic syndromes. And although historically, going back a few decades, people refer to the myelodysplastic syndromes as pre-leukemic syndromes, it's now recognized that only a minority, although it's a substantial minority, of all patients with MDS progress to acute leukemia. But a lot of that is dictated by the type of MDS, some very low risk of transformation to AML, and yet others with a much higher risk of progression to AML based upon the classification. And as we shall see, based upon a number of other important, primarily genetic prognostic factors. So there are three broad pillars that are central to the diagnosis of MDS. The first, of course, is peripheral cytopenias, and I'm not going to talk about that in any more detail. That's fairly straightforward, what the definitions are of those. But usual other accompaniments are morphologic dysplasia and genetic abnormalities, historically cytogenetics, but more recently molecular genetic abnormalities as well. So a question now for the audience, and I'd like this to be interactive, even though this is being conducted virtually, is to ask members who have not seen this talk before and who know the answer, that would be no fun if you knew the right answer, is where I took this photograph. I took this picture myself of these three columns that are required, or three pillars required to diagnose MDS. Does anyone want to tell me where I took this picture? And I'll pause for people to put their answers in the chat or to shout them out.
In Athens.
So one suggestion is Athens.
Two more votes for, we've got Athens, Greece, Ephesus.
So, and also I just want to point out, as an incentive for this, I think you can get double CPD points if you get the correct answer. So try and encourage more people to volunteer answers. So in fact, the correct answer is none of the above. This was actually taken in Philadelphia, where I am based in the United States, in Pennsylvania. although not exactly the same Philadelphia where I reside and work. This is Philadelphia. If I just turn that sign on its side, is actually in Amman, Jordan. And historically, Amman, Jordan, which is a very ancient city, at one stage in its existence was known as Philadelphia. Philadelphia, of course, refers to the city of brotherly love. And a number of Philadelphias are found scattered around the world, not only in the United States, not only a historic name of Amman, Jordan, but I also discovered recently there's a Philadelphia just a little bit north of Cape Town as well. I haven't had a chance to visit there. If anybody has any recommendations about visiting Philadelphia, Western Province, please let me know. Anyway, and as you may have, for those of you who were unlucky enough to see my previous talk, I have a sort of a tendency when I visit foreign cities to take pictures of street art. So I did the same here in Amman, Jordan. Interesting sort of robotic figure contemplating a paper ship with a rooster in a bottle. I'm really not sure of what the implications or interpretations of that are. Please share your thoughts on that. I would appreciate that. Interesting murals as well, sort of a face, half feminine, half masculine face in downtown Jordan. Some people added some words to some of the street art. The city is so empty, be nice or go away. Or one that I like in particular, which is a quotation from an older source, is don't talk unless you can improve the silence. And so I'm going to take that seriously, and I'm going to end my lecture. Thank you very much for your attention. Oh, all right, I'll carry on. To get back through to the three pillars or the three columns, peripheral cytopenia, I'm not going to discuss morphologic dysplasia. I'll touch upon, and I'll also spend quite a lot of time talking about genetics. We're all familiar with, and indeed, I think, enjoy looking at bone marrows and peripheral bloods to unravel and dissect and determine whether there are the classic morphologic findings of dysplasia as illustrated in the slide. In the top left-hand side is a classic bilobated or pseudo-pelgarized or pseudo-pelga-Hue anomaly of a hypolobated neutrophil that's also a bit hypogranular, sometimes referred to as the pince-nez abnormality. My French pronunciation, please forgive me, pinched nose, reflecting the glasses that are used that resemble the morphology of the neutrophils. And then top right and bottom right, of course, we have small hypolobated micromegakaryocytes. Bottom right in a bone marrow biopsy in which megakaryocyte morphology can be accentuated using a PAS stain. And on the left-hand side, some fairly profound dyserythropoiesis, excuse me. As we look around, we can find more morphologic abnormalities that typify a myelodysplasia. In the peripheral blood smear amongst the red cells in the top left are included things such as basophilic stippling, acanthocytes, even Howell jolly bodies and giant platelets can be seen, a variety of different neutrophil abnormalities in the center top, a ringed eosinophil towards the top right, ringed sideroblasts on a bone marrow iron stain, and an abundance of dyserythropoiesis and dysmegakaryopoiesis evident in the bone marrow aspirate and indeed also in the bone marrow biopsy on the bottom left. The separation of nuclear lobes, as seen in this prototypic morphologic example from a bone marrow aspirate smear, also evidence in a bone marrow biopsy in the bottom right here, or sometimes referred to, and I don't know if this terminology is widely used here, but it's something I learned about when I arrived in the US, was the pawn shop sign. And so this is a sign you may see and recognize if you've ever paid attention to signs hanging outside pawn shops. And this symbol apparently has its origins in the coat of arms of the Medicis. And if you've traveled in Florence, Italy, and you look at the many structures that the Medicis owned and built historically, you will find the symbol with three balls. They were merchants. And so this has been sort of adopted by pawnbrokers over the years. So pawn ball megakaryocytes is a term used to describe this morphology. I just wanted to share with you an anecdote when I was trying to, after I'd learned about this description with a resident or registrar with whom I was working in the US a number of years ago, and I was trying to explain what a pawn shop was, and I said to her, surely you've been into a pawn shop in your time, and she turned around and slapped me. I was a little bit taken aback, but it turned out it was just an issue with my accent. She thought I was referring to porn, P-O-R-N, which for the younger members of the audience was how historically people would satisfy their desire for pornography. There used to be shops. I don't even know if they exist anymore, because I'm told this sort of stuff is freely available on the internet. Anyway, I digress. Allow me to continue. As you know, the dysplasia, which we love and use to help think about a diagnosis of myelodysplastic syndrome, has many mimics, and many of the findings are not that specific. So it's important to be cognizant of the many situations in which there can be diseases that induce dysplasia but are not associated with myelodysplastic syndrome or myelodysplastic neoplasms. So a whole host of different infections, in particular viral infections, but even something as sort of vague and unusual as leishmaniasis can induce a dysplasia in the bone marrow. A variety of toxins, as you know, including heavy alcohol ingestion, zinc, and arsenic, can interfere with hematopoiesis and induce dysplasia. Drugs as well. In particular, recent chemotherapy can induce dysplastic changes. And I think it's always important not to overdiagnose underlying or residual dysplasia in patients who've been treated for a myeloid neoplasm, at least conservatively or liberally, depending on your point of view, for at least 6 months since they received chemotherapy. Growth factors, be they erythroid or granulocytic stimulatory or even megakaryocytic stimulatory agents, can induce dysplasia. Immunosuppressive drugs used in the setting of transplant or in the setting of autoimmune diseases can induce dysplasia, and of course, some antibiotics as well. Megaloblastic anemia due to B12 or folic acid deficiency can induce morphology that can mimic dysplasia, although to the astute eye, one should be able to distinguish the one from the other. Copper deficiency, vitamin E deficiency as well can induce morphology that mimics dysplasia. Rheumatoid arthritis, lupus, and autoimmune lymphoproliferative syndrome, amongst others, can induce abnormal morphology in the bone marrow. And there are a number of miscellaneous causes. Perhaps one we need to be most cognizant of that we learned about in the last few years are inherited bone marrow failure syndromes, in which germline mutations result in bone marrow failure. And yes, indeed, these patients are at risk for getting myelodysplasia, but they can display dysplasia in the absence of overt myelodysplasia. It's a bit of a mouthful there, but certainly something to be aware of. I think the bar for diagnosing MDS in these settings should be raised. And in fact, there are proposals that the sort of numeric definition of dysplasia, which is currently at 10% of cells, should be raised to 20% in a patient who is known to have an inherited bone marrow failure syndrome, just to ensure that you don't overdiagnose MDS when the morphologic abnormalities are really just a manifestation of the germline rather than a somatic genetic abnormality. In patients with profound hemolytic anemia, stress erythropoiesis can also look a little bit funky. So many different morphologic considerations to exclude before you jump on the MDS bandwagon. Although we rely primarily, as you know, on the bone marrow aspirate, there are some features in the bone marrow biopsy that can be telling. So certainly hypercellularity is a fairly characteristic finding in patients with MDS, but there is a well-recognized hypoplastic MDS or hypocellular MDS tends to be seen more commonly in children, and it can be tricky to distinguish this from aplastic anemia, and indeed also what I alluded to previously, the genetic predisposition syndromes, inherited bone marrow failure syndromes. ALIPS, or abnormal localization of immature precursors, where immature cells, promyelocytes, etc., which normally would sort of abut upon bony trabeculae, are now localized within the more interstitial regions far away from the bone marrow trabeculae, is another histologic feature of MDS. Dysmegakaryopoiesis, of course, I think is generally much easier to appreciate on biopsies than on aspirates, whereas aspirates are more likely to be helpful in picking up dyserythropoiesis and dysgranulopoiesis. Architectural disarray, particularly disarray of erythroid islands, is sort of oft-repeated feature, difficult to quantify, difficult to determine objectively, but it can be done sometimes with sort of immunohistochemical aids and some machine learning techniques, which is something we utilized recently in our laboratory. And of course, fibrosis can be seen in myelodysplastic syndromes. Fibrosis, of course, in the setting of a hematologic malignancy, has a fairly broad differential diagnosis, primarily focusing on primary myelofibrosis, the myeloproliferative neoplasm, but usually the sort of characteristic megakaryocyte morphology, the clinical features of splenomegaly, and the genetic profile ought to be able to make you to distinguish MDS with fibrosis from primary myelofibrosis, two very different biologically, genetically, and clinically different diseases. Interestingly, the WHO, but not the International Consensus Classification, have included as subtypes the two items that I've mentioned on the slide, MDS that is hypoplastic, as well as MDS with fibrosis, separating them out as different categories. With regard to the genetics of MDS, of course, cytogenetics has been and still continues to be an important facet of diagnosing and characterizing myelodysplastic syndromes. However, it's important to recognize that only approximately 1/2 of de novo cases of MDS have a clonal karyotypic abnormality as discerned by chromosomal banding analysis. In other words, 1/2 will have a completely normal karyotype. So therefore, having an abnormal karyotype cannot be used, should not be used, must not be used to exclude MDS. If the MDS is arising in the setting of prior cytotoxic chemotherapy, you're much more likely to encounter an abnormal cytogenetic finding up to 90% of cases. And unlike, for example, acute myeloid leukemia, CML, and many B-cell neoplasms in which there are usually translocations that are the sort of primary driving genetic chromosomal abnormality, in myelodysplastic syndromes, this is different. They tend to be unbalanced losses or gains, as you know, affecting chromosomes 5, 7, and 8, for example. In general, and it's my opinion, and I think the literature, supports this, and it's one of my soapbox issues, is that FISH analysis is abused and overutilized in diagnosing myelodysplastic syndrome. If you have a good karyotype, and by a good karyotype, depending on the standards established by your laboratory, generally 20 metaphases, but some laboratories may only go down to 10 metaphases, and you don't find an abnormality, the likelihood of picking up an abnormality by FISH analysis is very, very small and is of no added value. And really, FISH should only be reserved for cases in which there is an inadequate, a technically inadequate karyotype. Should not be done in all cases. Array CGH and SNP arrays may have a role, and certainly a lot of publications highlighting this, although this really hasn't been adopted in a widespread fashion in clinical laboratories. I certainly have no experience with this. We don't do it in our lab, but there are some reference laboratories mainly, and a couple of academic labs in the US that do this, but I think it's still a minority of institutions. Moving beyond the karyotype and what can be discerned from arrays is, of course, molecular genetics. And at least 90% of MDSs have detectable mutations on standard, whatever that means, standard myeloid panels. And so the false negative, you're much more likely to find a mutation than you are to find a chromosomal abnormality, is, I suppose, the take-home message from this slide. Let's just look at a little bit more detail of the chromosomal abnormalities in MDS. This really has utility in three broad situations: diagnosis, classification, and prognosis. And so there are some MDS-defining cytogenetic abnormalities, and these have been whittled down for whatever reason, as compared with the WHO from 2016 or 17, which was the revised 4th edition, in which there were more than 15 MDS-defining cytogenetic abnormalities. These have been dramatically reduced by the International Consensus Classification to just abnormalities, deletion 5, deletion 7q, monosomy 7, and complex cytogenetics, whereas WHO only recognizes 5q minus del 5q as MDS defining. So a lot easier to handle these fewer cytogenetically defining types of myelodysplastic syndrome. In addition, of course, cytogenetics are central to classification, with in particular MDS with del5Q. If you have a del5Q on its own, that's great, but you're allowed one additional abnormality as long as it's not del7Q or monosomy 7, you can diagnose this generally indolent form of myelodysplastic syndrome with classic morphology. With regard to prognosis, in 1997, so quite some time ago, over a quarter century ago, the International Prognostic Scoring System by Peter Greenberg et al. Only had 5 cytogenetic abnormalities that were considered to be prognostically relevant. This was updated 15 years later in 2012 with the IPSSR, R standing for revised, in which now 19 cytogenetic abnormalities as listed in this table were determined to be of prognostic relevance. And just looking at some of the features, normal cytogenetics, del5Q amongst others, are associated with a good prognosis, which accounts for the bulk of patients, whereas abnormalities of chromosome 7 are generally worse. Abnormalities that include loss of chromosome Y and deletion 11q are actually considered very good, which is kind of unusual and a little bit counterintuitive in a way, in that these patients with MDS with these cytogenetic abnormalities do better than those that have normal cytogenetics. A little bit more detail is that complex cytogenetic abnormalities with 3 or more abnormalities, of course, are extremely poor prognostically. Same story as in acute myeloid leukemia, as we discussed a few weeks ago. With regard to median survival, those with very good prognosis have a relatively good median survival of over 5 years. In contrast, those with very poor cytogenetics have a very dismal outcome with median survival less than 1 year, with many patients transforming into acute myeloid leukemia. In contrast to those with very good cytogenetics, the median survival time point has not yet been reached. So highlighting the very important prognostic value of cytogenetics in myelodysplastic syndrome. What about mutations? Well, with the advent of whatever you want to call it, next generation sequencing, high throughput sequencing, or massively parallel sequencing, a number of different new genes have been noted to be defective and mutated in myelodysplastic syndromes, and roughly 40 to 50 genes are recurrently mutated in the myelodysplastic syndromes. There are approximately 9 coding somatic mutations per case, which consists of 2 to 3 driver mutations, but it's very heterogeneous. No single gene is mutated in more than 25% of cases, and other than SF3B1 and TP53 that we'll discuss in a little bit more detail shortly, no mutation can be used for diagnosis. So this bar graph highlights the groups of genes that are commonly mutated in myelodysplastic syndromes, and those affecting splicing factors SF3B1, SRSF2, U2AF1, and ZRSR2 are the most common group of genes that are mutated in myelodysplastic syndromes. The others listed there are also genes that you'll encounter, as with the splicing genes, in AML, but they have different rates of occurrence in the 2 different disease groups. And what I've highlighted in red and in blue, the red mutation SF3B1 is known to be a good prognosticator on its own, whereas many of the others, the ones in blue in particular, when present, are associated with a relatively adverse outcome. So mutations can be of relevance with regard to prognosis as well. I did highlight and mention that many of the same groups of genes are mutated in AML. But if you look at this nice summary of the mutations that are found in AML as opposed to MDS from a paper from Sheishi Ogawa from 5 years ago, at the top in red are the abnormalities or the genes that tend to be mutated in acute myeloid leukemia. And of course, we recognize FLT3, NPM1, CPB alpha, and others that are much enriched in AML, but not in MDS, whereas in particular, the spliceosome genes in blue at the bottom are more enriched in the myelodysplastic syndromes, with SF3B1 perhaps as a singular gene being most associated with MDS. But one has to be careful. SF3B1 is certainly not specific for MDS, and it alone cannot be used to diagnose MDS. Indeed, it's one of the more commonly mutated genes in CLL, roughly 15% of patients with CML, obviously a completely different hematologic malignancy affecting lymphocytes and not myeloid cells, B cells and not myeloid cells, and is a chronic neoplasm as well. But you can find SF3B1 mutations in CLL. Similarly, PMF, primary myelofibrosis, may be associated with SF3B1 mutations. And of course, there are a host of non-hematologic neoplasms that are enriched in these mutations, in particular of all things, uveal melanoma, more so than the more common cutaneous melanomas are enriched in SF3B1 mutations. With regard to sequencing and diagnosis, as I've mentioned before, there are two forms of MDS that can be diagnosed based upon mutations, as long as you have an associated cytopenia. And those two mutations are SF3B1 and TP53. And whereas, morphologic dysplasia is typically present in such cases, it is not required. In other words, if you have a cytopenia and one of these mutations, you can diagnose MDS in the absence of a morphologic dysplasia. So there are now a total of 3 forms of genetically defined MDS, SF3B1, TP53, and of course, DEL5Q. And I think in the future and future incantations of classification schemes, there will be more and more genetically defined forms of MDS. As I mentioned before, approximately 90 to 95% of patients with MDS have a mutation in typical panels that, contain a reasonable representation of myeloid genes, 40 or 50 myeloid genes. You ought to be able to pick up a mutation. So in other words, the absence of a mutation has a reasonable, but obviously not perfect, negative predictive value for MDS in a patient with a cytopenia. And in terms of what specimen to test, unlike some other diseases, in particular AML, in which in general, marrow may be better than peripheral blood, in MDS and also the myeloproliferative neoplasms, which we're not talking about, peripheral blood is as good for mutational analysis. A little bit more expanding on SF3B1 and TP53. SF3B1, to be included as a criterion for diagnosing MDS, must have a variant allelic frequency or fraction of greater than 10%, since SF3B1, as we'll see later, can also be a CHIP mutation in which the cutoff is 2%. So you need to have a fairly sizable representation of the SF3B1 clone to be included. And this sort of has supplanted what was previously called MDS with ring sideroblasts. And this emerged because it became clear that not all MDSs with ring sideroblasts are created equal. Perhaps 90-ish% of them have the SF3B1 mutation, and they do well. By contrast, the other roughly 10% that lack this mutation do not do as well. So that sort of is what underlies the decision to make this a genetically defined rather than a morphologically defined entity in the recent classification schemes. Because, as I mentioned, those without the mutation but with ring sideroblasts do worse and seem to be a biologically different disease. Also, you're not allowed to have a number of coexisting genetic abnormalities. Difficult to remember them all, but there are a number of factors that, if seen together with an SF3B1 mutation, multi-hit TP53, RUNX1 mutation, DEL5Q, DEL7Q, monosomy 7, abnormal 3q26, and complex karyotype, you cannot make this diagnosis because that will actually change the biology of the disease. With regard to TP53 mutated myelodysplastic syndromes, unlike AML, which we spoke about a few weeks ago, where TP53 mutations can be used to diagnose a subtype of AML, in MDS, they must be multi-hit. There are a number of studies that have shown that a so-called single-hit TP53 mutation in just about all studies has to be present in MDS to be used as a criterion for diagnosing P53 mutated MDS. So there are 5 ways to get into the TP53 mutated MDS club. The easiest 2 ways are if there is more than 1 mutation, 2 or more mutations, each with a variant allelic fraction of more than 10%, or if there's 1 mutation with a variant allelic fraction of greater than 50%, or if there's 1 mutation with a VAF between 10 and 49% in the setting of a complex karyotype, 3 or more abnormalities, or if there's 1 mutation with a VAF again of 10 to 49% and deletion 17p on karyotype or FISH analysis, Or finally, and most difficult to diagnose, since most laboratories are not doing this testing, yes, you can detect a P53 mutation with a VAF of 10 to 49%, but you need to do CGH or SNP arrays to determine if there's LOH, loss of heterozygosity of 17p. Most labs, including the lab I work in, do not do that, but a number of other ways to get into the club of TP53 mutated MDS. But wait, there's more. So we talked about the IPSS from 1997. We talked about the IPSS-R from 2012. And now 10 years later, 2 years ago, emerged the IPSS-M, which for the first time in terms of prognostication, this is prognostication, not classification, and not diagnosis, prognostication, has entered into the realm 31 genes that are relevant for characterizing prognosis using mutations. There are 16 so-called major effect genes, 15 so-called residual genes. As their names suggest, the major effect genes appear to be more biologically relevant. They are listed here. Impossible to remember them all, but I'm highlighting these three: TP53 multi-hits, KMT2A partial tandem duplication, and FLT3 mutations seem to have the most negative effect when present in a myelodysplastic syndrome. Also wanted to highlight, and I touched upon this before, SF3B1 mutations are generally good, but they're not universally good, and it depends on what other genetic abnormalities are present at the same time. And then on top of that are the 15 residual genes. So a total of 31 genes, according to this study, that are prognostically relevant. Difficult to remember. Not every panel that exists out there today has all 31 genes, but what exists is an online tool that allows you to plug in what information you have about the mutations in your patient. And it doesn't matter too much if there are missing data, but you can access this online tool and then plug in other parameters, not just mutational profiles, to discern what seems to be today the most accurate way of prognosticating the myelodysplastic syndromes based upon integration of mutations along with other more traditional clinical and laboratory parameters. So as of 2022 or 2024, nothing's changed since then. We use for diagnosis mutations of SF3B1 and TP53. They can be also used for prognosis, as I've highlighted. They might also be used, although this is not completely and sort of definitively established just yet, for prediction of response to therapy. So certain mutations might predict for improved response to hypomethylating agents. Some might predict for decreased response to hypomethylating agents. And SF3B1 mutations may predict for response to spliceosome inhibitors. Yet others have looked at multiple genes at the same time and used computational biologic modeling and digital drug simulation to predict responses to therapy dictated by the mutational profile. All right, so time for another brief scenic interlude. This picture I took on the same wonderful trip to Jordan. We've now left Amman, where I showed you the 3 columns or the 3 pillars in Philadelphia, which is what Amman, Jordan was known as. And I think we're now in Jerash, another area where there's a lot of Greek and Roman ruins. This is, can anybody tell me what this is? Another sort of interactive facet of this session. Anybody been to this part of Jordan? This is like a canyon that one walks through to Petra. And Petra is considered by some one of the 7 wonders of the ancient world, where these wonderful sort of sandstone formations with wonderful colors and texture to them. And of course, Petra is known, once you make it through the canyon, to these amazing rock carvings where they've carved structures out of the rocks, as illustrated here. The rocks have this sort of wonderful pinkish hue, and I think Petra is sometimes referred to as the Rose City because this color sort of resembles the color of roses. Beyond Petra is this region. Where am I now in Jordan?
Someone says L-sick.
IL-6?
L-sick, S-I-Q. And by the way,
Oh,
we had 2 correct answers for Petra from
yay,
Bloemfontein.
yay, yay. Okay. So Petra's not in Bloemfontein, but it's you can get a direct flight, I believe. So this, L-sick, I don't know. I have
That's
not.
Wadi Rum, isn't it?
Yes,
That's
it is Wadi Rum.
Yes.
Beautiful. So
Yes, it is.
who's that? Who's talking? I need.
Sorry, it's Melanie. I was in Petra last year. That's why.
Oh,
And I went to
fantastic.
Wadi Rum.
You went to Wadi Rum?
Yes, yeah.
Fantastic. Did you camp there?
We had we spent the day there, so we had a picnic in the
Fantastic. And so to complete our conversation, what movie was filmed there?
Yeah, they told me. Was it one of those sci-fi movies, Aliens or Dune or something or the other? I can't remember. So Indiana Jones was in Petra, but Wadi Rum, of course, was
Yeah,
one of
I
those
think
kind
Wadi
of
Rum,
movies.
historically, for the old farts on the call like me, Lawrence of Arabia.
Oh my
probably,
God.
I
Okay.
think in the 1960s, whenever that movie came out with Peter O'Toole, was filmed. But more recently, you're right, sort of science fiction Mars. And since you mentioned June, of course, June was filmed closer to home. I think parts of June was filmed in Namibia. Do people want to continue talking about MDS, or should we talk about sort of wonders of the natural world and movie associations? Should we take a quick poll on that? All right, I'll carry on with the MDS story. This was another picture I took at Wadi Rum, just glorious sort of landscape, and you can see how it looks sort of Martian. Not that any of us has been to Mars, but part of the film Mars with Matt Damon was filmed there. All right, so back to boring MDS. Sorry, it's only for so long I can use these divergences. So the point is, if there's so many mutations that are found in the myelodysplastic syndromes, 90 to 95% of patients with MDS have a mutation. Why can't we use more mutations other than SF3B1 and PP53 to diagnose MDS? After all, here we see that roughly or more than 90% of patients with MDS have a mutation. And we've talked about some of them here, not all of them. And of course, the primary reason is because of this recently or fairly recently described entity of CHIP, clonal hematopoiesis of indeterminate potential, in which by definition, there is a mutation in every single patient. That's what defines them. And you can see that many of the mutations that are found in MDS are also found in CHIP, although with different frequencies. So instead of spliceosome factors being mutated in a quarter of patients, they're only in about 5% of patients. Much more commonly is DNA methyltransferase 3A with TET2 and ASXL1 commonly seen after that. And you may ask the same question, then surely we can use mutations to distinguish MDS, in particular hypoplastic MDS from aplastic anemia. And there too, I think you'll get into trouble if you just broadly use that sweeping statement, since we now recognize that roughly 80% of patients with aplastic anemia can harbor mutations, and many instances of aplastic anemia are actually have some evidence of clonality. Although here again, although there's a lot of overlap, there's quite striking difference in the different gene types seen in aplastic anemia, with the two on the right, in particular, PIG-A genes, BCOR and BCOR-L1, dominating in aplastic anemia and are relatively infrequent or hardly ever seen in the setting of pure MDS. And sort of to that point, about 10 to 20% of MDS cases, as I mentioned in one of my much earlier slides, are in fact hypocellular rather than the expected hypercellularity. But the genetic profile can help push you in one direction or another. As I mentioned on the previous slide, if you have a BCOR or BCOR-L1 or a PIG-A gene mutations, of course, are the ones that are prototypically seen in PNH, you're more likely dealing with aplastic anemia. By contrast, if you have a mutation of a spliceosome gene or one of the cohesin complex genes, you're more likely to be dealing with the myelodysplastic syndrome. So they can be somewhat helpful in that regard. Talking a little bit more about CHIP, on which there's been an abundance of literature in the last decade. This was only described about a decade ago, initially by Sid Giswell from Stanford in this seminal paper in the New England Journal of Medicine, showing that as we age, we are more likely to encounter somatic mutations, so that in your 70s, roughly 10% of individuals will have a mutation, and as one progresses older and older, the likelihood of finding a mutation increases. The defining features of CHIP are threefold. These are acquired, importantly, they're not germline, these are acquired somatic mutations which are known to be associated with hematologic malignancies or neoplasia that are seen in the absence of both cytopenia and dysplasia. In other words, there is no evidence of a hematologic neoplasm. All that is present is a mutation. The big three are the DTA mutations. Most common of all is DNA methyltransferase 3A, accounting for over or at least 50% of CHIP mutations, less commonly TET2 and ASXL1. All three are, of course, genes involved in epigenetic regulation, be it at the DNA level or the chromatin histone level. By definition, the VAF, variable allele fraction or frequency, needs to be more than 2%. And this was just because the limit of detection, that was the limit of detection at the time using whole exome sequencing. If you use more sensitive technologies beyond whole exome sequencing, which is not very sensitive, you will find CHIP in just about every individual, including in very young patients. So the sort of cutoff, numeric or quantitative cutoff, is an important one. And it's known to be a precursor state for hematologic malignancies, such as MDS and AML in particular, and is somewhat analogous to MGUS as it is to plasma cell myeloma or multiple myeloma, MBL as to CLL, or in situ follicular neoplasia as it is to follicular lymphoma, although these CHIP lacks anatomic or immunophenotypic equivalents, which are present in the other examples provided. The risk of progression to an overt neoplasm, be it MDS or AML, is relatively low, 0.5 to 1% a year. And since these manifest usually in elderly patients, and although they obviously have an increased risk for hematologic malignancy, this only afflicts a minority of patients with CHIP mutations. CHIP is not a phenomenon, or clonal poiesis is not restricted now to the hematopoietic system. It's known to affect other systems. So there's clonal skinopoiesis of indeterminate potential, and clonal esophagopoiesis of indeterminate potential, and clonal colonopoiesis or endometriopoiesis of indeterminate potential, with it being described in these other organ systems as well. Just to expand upon the analogy I alluded to before, if you look at patients with MGUS or monoclonal abnormality of undetermined significance, yes, they may progress, but they only progress at about 1% a year. And in general, most patients do not progress, and they die from unrelated causes. Similar analogy is monoclonal B-cell lymphocytosis progresses to CLL in 1 to 2% of patients per year. Majority of patients do not progress, and death is from unrelated causes. And the similar pattern has been proposed for CHIP, in which the progression rate, as I mentioned, is roughly 0.5 to 1% a year, no progression in most patients, and death from unrelated causes is not the case. In fact, it's been shown more subsequent to this initial paper that CHIP is in fact associated with death from unrelated not from unrelated hematopoietic causes, but from other causes related to the presence of clonality. Those of us sitting around a microscope, scratching our heads, trying to make a diagnosis of a hematologic disorder on the bone marrow or doing ward rounds, you may utter either under your breath or loudly a 4-letter word. So there are now an increasing number of 4-letter words we can utter in the context of these diseases. We've talked about CHIP and how to diagnose CHIP. A related entity is ICUS, idiopathic cytopenia of undetermined significance, in which there's just a cytopenia but no mutation. CCUS is the combination of a cytopenia and a mutation, clonal cytopenia of undetermined significance, but no morphologic dysplasia, and not meeting criteria, for example, of FF3B1 or TP53 mutated MDS. Then there is ARCH, age-related clonal hematopoiesis, which some people have used as being analogous to CHIP. There are some subtle differences. There is CHOP, which is not, the standard chemotherapy that has been used for decades to treat lymphomas, but clonal hematopoiesis, not of indeterminate potential, but rather oncogenic potential. And a few others have emerged over the years. But in this great study published by Luca Malcavati from Italy a number of years ago, shows the importance of distinguishing ICAS from CCAS. ICAS is just a cytopenia with no mutation, whereas CCAS is a cytopenia with a mutation, with a very dramatic difference in the cumulative probability of evolving to a myeloid malignancy, 9% in ICAS, 95% in patients with CCAS after following them for a decade. The greatest risk of patients with CCAS progressing to an overt hematologic malignancy was when they had one of the 3 listed spliceosome mutations, or if they had one of the DTA mutations and another mutation. So important to distinguish ICAS from CCAS. But it's important to distinguish CHIP both because of hematologic and non-hematologic malignancies. As mentioned a few times now, there's an increased risk of myeloid neoplasms in patients with CHIP, although the majority of patients will not progress. And there's an increased risk in particular of therapy-related myeloid neoplasms, in particular in patients who have CHIP of these 3 genes, TP53, PPM1D, and CHEK2, all involved in DNA repair. And historically, the sort of dogma was that chemotherapy was causing mutations that gave rise to therapy-related myeloid malignancies. It's now understood that these mutations already pre-exist in these patients as CHIP mutations, and they expand in the setting of chemotherapy and can sometimes be detected if you do genomic profiling of a solid tumor, for example, a breast carcinoma, and you find one of these mutations. It's not in the breast cancer, but it's in a tumor infiltrating leukocytes, and you can predict those patients are at increased risk for getting a therapy-related myeloid neoplasm. There's also an increased risk of donor-derived neoplasms in the setting of allogeneic transplant. Interestingly, there may be some benefit if there's an increased graft versus leukemia, which would be beneficial. In autologous stem cell transplants, the CHIP clone expands after transplant, so there's a greater risk of therapy-related myeloid neoplasms, and generally bad news. So the question is, should patients undergoing autologous stem cell transplants be screened for the presence of CHIP mutations? Should donors be screened for the presence of CHIP mutations as well? And that's being thought of and may be done in some centers, I'm not sure. There's also an increased risk of AML relapse if you have a CHIP mutation, but depending on which CHIP mutation is present, not for the common DTA mutations, which seem to be the most sort of benign in this context. More reasons why CHIP matters. As I've alluded to before, they can predict outcomes in aplastic anemia. So the PIGA, BCOR L1 mutations in patients with aplastic anemia generally portend stable disease or disease that may resolve spontaneously or improve spontaneously, and that may indicate a benign course. DNA methyltransferase 3 or ASXL mutations tend to expand in aplastic anemia, and these patients will then likely develop a myeloid neoplasm. There's increased risk, and this is something that's sort of a lot of people have focused on more recently, a risk of all-cause mortality in patients with CHIP mutations. And this is largely due to the increased risk in vascular disease, both cardiac and cerebrovascular accidents. And the risk for getting these vascular diseases is as great as it is from smoking and hyperlipidemia. And so patients with CHIP mutations and CHIP clinics that are emerging in certain parts of the world are more likely to be populated by cardiologists than they are by hematologists. And mechanistically, this is thought to be due to the presence of clonal macrophages. Macrophages, of course, being derived from hematopoietic stem cells, with their aberrancy and clonality affecting accumulation of lipids and giving rise to a greater incidence of cardiovascular and cerebrovascular diseases. There's also an increase of other diseases, type 2 diabetes, chronic obstructive pulmonary disease, chronic graft-versus-host disease, and CHIP is really now considered a pro-inflammatory state. But there are different flavors of CHIP, as we know, and I apologize for not having included a picture of Simba chips. I'd initially made this for a US audience who their loss are not familiar with Simba chips. In any case, if you have more than one CHIP mutation, and if the variant allelic frequency is greater than 10%, and if specific genes are involved, such as SRSF2, U2AF1, both spliceosome genes, TP53, JAK2, RUNX1, and IDH genes, in general, these patients have a particularly heightened risk of developing AML, and they have the same outcomes as patients with low-grade MDS. And I made this slide actually a couple of years ago and sort of thought and predicted that the newer classification systems that came out in 2022 would incorporate these as low-grade MDS based upon certain flavors of chips. That did not happen. The groups decided to be a little bit more conservative, but maybe the next classification systems will do so. So the consequences of clonal hematopoiesis, and I've got of indeterminate potential, are quite frequent, and I've got IP in parentheses only because the potential may not be as indeterminate as one thought. So there's a heightened risk of hematologic cancers, as we know. As we've discussed, ischemic cardiovascular disease, atherosclerosis, myocardial infarcts, ischemic heart failure, stroke, as well as chronic liver disease, chronic kidney disease, COPD, osteoporosis, hypercoagulability, and gout. The risk of all of these diseases is increased in patients who have CHIP. By contrast, and intriguingly, there's a decreased risk of one disease in patients with CHIP, and that's in patients with Alzheimer's disease. If you have a CHIP mutation, the good news amongst all the bad news illustrated on the right-hand side is that you may have a decreased risk of developing Alzheimer's dementia. Reasons unclear, but maybe something to do with the fact that microglia in the brain, like the macrophages we talked about earlier, are hematopoietic in origin. So there is probably a biologic link there. In the end, why do mutational testing in the MDS? You need to do it for classification. SF3B1 mutation supersedes now MDS with ring sideroblasts. TP53 multi-hit mutations is now a subtype of MDS, and the modalities and numbers and types and associated factors differ from those to diagnose AML with mutated MDS, mutated P53, excuse me. Also kind of helps exclude a diagnosis of MDS. Although imperfect, about 90% of patients with MDS will have a mutation on most standard panels, but of course the absence of evidence does not imply evidence of absence. We've talked about prognostication, the 31 gene panel from Elsa Barnard and colleagues. Also, we talked about predicting response to therapy. There are some mutations that predict a good response to hypermethylating agents. In a paper from the MD Anderson group just a week or so ago, this is one updated slide for those who may have encountered this talk previously, is that splicing genes, when mutated, may predict for a good response to hypermethylating agents and venetoclax, which has increasingly been used to treat amyloid neoplasms, whereas TP53 and RAS mutations will predict for a poor response to hypermethylating agents and venetoclax. Also, you may identify a potential therapeutic target. Certainly IDH2 inhibitors, IDH1 and IDH2 inhibitors are already available in clinical practice. Maybe spliceosome inhibitors will be present and available in the not too distant future. You can also do mutational testing to monitor residual disease and also to gauge response to therapy. Also, and something I sort of touched upon earlier, but haven't really focused upon, is to identify germline or potentially hereditable mutations, which are relevant in a number of scenarios, but also may affect donor selection. If a patient with MDS is being considered for stem cell transplant and you're looking at a related donor, it would be very important to ensure that that related donor doesn't have the same germline mutation that spawned the myelodysplastic syndrome in the first place in that patient. And although there's a tendency to think of germline mutations primarily in the context of young patients who develop MDS or AML, That's no longer valid nowadays, in particular with DDX41 mutations, a germline mutation in which patients get MDS at the usual age in their 60s and 70s. So very interesting in that regard. Also, sometimes on panels, you may identify an unexpected other mutation that may have something biologically to do with the cause of the cytopenias. For example, if you saw a STAT3 mutation, STAT3 mutations are not known to occur in MDS to any degree, but may make you think of an underlying T or occult T, large granular lymphocyte leukemia, that was actually the cause of the cytopenias. Similarly, a KIT mutations not common in MDS, may make you scratch your head and say, I wonder if there was an occult and a missed systemic mastocytosis. BRAF mutation, again, not common, but do occur in myeloid neoplasms. Maybe there was a hairy cell leukemia that was, rather sneaky, and we missed that. So the presence of one of these mutations may be a value of saying, maybe it's not MDS, and maybe it's some other hematologic neoplasm. So to summarize, and we're getting towards the end now, the features, the mechanisms and genetics of MDS, we talked about how it is essential to make a diagnosis of MDS that you have a cytopenia. In many but not all instances, there is dysplasia. And in many and most instances, now that one incorporates mutational testing, there is a genetic abnormality. And of course, it's the dysplasia, which is the morphologic manifestation of ineffective hematopoiesis, that is driving the cytopenia, with the dysplasia almost certainly a consequence of the genetic abnormality. But it's not only that, there is pyroptosis and other biologic pathways that are disrupted in patients with myelodysplastic syndromes. In the end, it's essential to do genetic testing in MDS. Cytogenetics still today is very important for a variety of reasons: diagnosis, prognosis, classification, maybe even therapy selection. 5q minus syndrome, or MDS with del5q, and the treatment with lenalidomide, for example. FISH, I've alluded to without much fanfare, because FISH is really not of added value if you have a good karyotype. Array CGH, SNP array done by a minority of laboratories can be of help in rare situations. Mutation detection is essential to do using targeted panels, have an increasingly important role, despite or perhaps because of the importance of CHIP. My last talk, I interspersed that, as you may recall, for those who were present, with some pictures of my daughter. Some people felt that was unfair, that I used pictures of her. I did, and that it was even cruel. I've decided to mix things up a bit for this talk and show pictures of my cats, whom I left at home in South Africa. Not only did I get permission from the cats, I got permission from the SPCA to show this picture of Badubadub. I'm happy to answer questions as to the origin of the cats' names. I would also add that these pictures, unlike Princess Catherine, I took these pictures myself. They have not been retouched. These are the authentic original pictures and can be reproduced. This is Badubadub really looking bored after one of my practice iterations of this MDS lecture, looking very cool and calm there, loves to have our tummy tickled. The other cat in our household is a Presh Angel, illustrated here, has an affinity for peaches. But even in this picture, Badubadub, who likes attention, photobombing in the background. I thank you very much for your attention and questions and interaction, and I'll be happy to take any more questions if there are any.
Thank you so much for this excellent presentation, Adam. We do have some questions and comments. The first is from Dr. Jacques Malherbe, who is a clinical hematologist in Bloemfontein. Jacques, if you are there, would you like to unmute and pose your questions and comments? You also had a comment about the wadi.
Let me just...
Okay, you're muted now,
Sorry.
Jacques.
Yeah, no, we had multiple computers here, so that's why.
Okay.
Just regarding the, just when you mentioned the wadi, there's a very interesting owl that occurs there in the wadis of Jordan, in that area, called Hume's owl. I was wondering if you may have seen it while there. but I think it's relatively rare. You need to go out specifically to find it. But my question is relating to so SF3B1 is good in generally a good mutation in MDS, but as far as I understand, if you detect this mutation in AML, it's got quite a bad prognosis. We actually currently have a patient with SF3B1 mutated AML. I was just wondering why this disparity in the mutation, usually good in MDS, but in AML, it has a, any explanation for that discrepancy in significance?
We'll get to the more important comment about Wadi Rum. Did you say elm or owl? A tree or a bird?
A bird, a human owl. Yeah.
Oh, wow.
It's quite a beautiful owl.
I would have loved to have seen that. I've been following, and I don't know if anybody here has been following the story of Flacco, an owl in Manhattan.
No, not heard of that.
Flacco was an owl in a zoo in Central Park in Manhattan that someone decided about just over a year ago in the middle of the night to cut open the cage. And for a year, this owl has been flying up and down throughout Manhattan. And people in Manhattan have fallen in love with Flacco the owl. And there are like lots of pictures of Flacco the owl. That's a Eurasian eagle owl, not native to North America, but that's had a wonderful life for the past year, free as a bird, so to speak, but unfortunately died a few weeks ago after flying into one of the skyscrapers in Manhattan. So if you're an owl person, I thought I would add that. But to get to the question about SF3B1, the reason why it's associated with a good prognosis in MDS, I don't know if the biology of that has been explained. And if anybody on the call knows the link between good prognosis in MDS and SF3B1 mutations, I'll be delighted to learn about that. I think with regard to its presence in AML, however, I think it's just largely a surrogate for a non-de novo AML, but rather an AML that has arisen from MDS. So sort of kind of supplanting the previous category of AML patients, AML MRC, AML with myelodysplasia-related changes. We now have this group of AML with myelodysplastic syndrome associated gene mutations, of which there are now 9 mutations, and SF3B1 is one of them. So I think it's just a surrogate for an antecedent MDS. So it's rather the fact that it's come from MDS rather than there's just the mutation itself. And obviously once, an AML emerges from an MDS, that's generally bad news, as you know. So I think that's sort of a hand-waving explanation for that distinction.
Jonathan Oxen made a comment to that same sort of theory, so it makes sense.
Yeah.
Thank you
I
very
think what's
much.
fascinating is, sorry, Jessica, what's really fascinating is, and I'm not sure you would know better than I, because I don't follow the clinical world that much, but the sort of idea of using spliceosome inhibitors as a therapeutic entity. I don't know if there are any trials from which data have emerged, but this is sort of fascinating utility where a spliceosome inhibitor, as my understanding, is a drug that'll kill the wild type protein, but not the mutant protein. And cells then have got a mutant protein, and that's all, will die. Whereas if you kill one mutant protein, kill the wild type protein, but you still got the other allele that's working in a patient with an SF3B1 or other spliceosome mutation, normal cells won't be affected, but it will specifically affect those cells with the mutation, which is theoretically very interesting, but I don't know what the clinical success has been, if there are any reports out from the clinical trials. Sorry, Jessica, I interrupted you.
No, there was another comment from Caroline Stain. Caroline, are you there? Would you like to unmute yourself? She's also a clinical hematologist from Bloemfontein. I think you're still working in Bloemfontein, Caroline.
Hi, Jessica. Yeah, I'm still working in Bloemfontein. I haven't left yet. Not planning to leave. So no, I was just sort of commenting on that multi-system involvement of CHIP and sort of the inflammatory sequelae that are seen, and just kind of interested as to why CHIP increases the risk of COPD. I was just wondering if it's a sort of a cause or an effect. Is it really that it's an independent risk factor for COPD, or is it not maybe just a little bit of detection bias because of the fact that people who are possibly, you know, smoking are attending the CHIP clinics because they also have atherosclerosis because,
Yeah.
you know, they're being seen by cardiologists. So it was just, I was just wondering about that, but I suppose it's likely part of the whole inflammatory milieu.
Yeah, I think you're right. I mean, I don't know. I don't think it's ascertainment bias because the people who have done these studies have sort of done all the right things epidemiologically to show that it is a real association. And, you know, just, you know, all these inflammatory states, CHIP is causing inflammation. Inflammation is causing chicken and egg story. I think, at least in my mind, it's not entirely clear, but still an important sort of biomarker of sort of chronic inflammation. But what comes first, I think, you know, as you pointed out, it's not entirely clear, the inflammation or the CHIP. But they certainly, you know, they sort of are partners in crime and tend to occur together, is my understanding.
Okay, I think that's we've come to the end of our discussion and questions, unless anybody else has something more that they would like to ask Prof. Bag or comment on before we close. I'm not seeing any last minute questions, so it just remains for me to thank you very much for a very enlightening, provocative talk. Really, really enjoyed it and learned a lot, and I'm sure everyone in the audience did. So thank you very, very much, and we look forward to your next lecture in the series, which I think is in 2 weeks' time. Thank you very much, Adam.
Thanks very much, Jessica. Thanks again for hosting and having me.
Pleasure. Bye-bye, everybody.
Bye.
Lots of thank yous coming up on the chat, Adam. An excellent talk, great talk, etc. I'll try and copy them.
Thanks, Jessica.